Good evening and good afternoon or good morning, wherever you're tuning in from today. It's great to see you on another edition of our NSWOCC and Walk Institute Continuing Education webinar series. This is part 5 of the webinar series that we've been hosting throughout this winter, spring, and now almost summer on wound care strategies for keeping the patient at home and in the community. And today I'm joined by one of our guest speakers who you've heard from before during our part 2 session, Dr. Robyn Evans. And before I introduce Dr. Evans, I'll just go through a couple housekeeping items. First things first, I'll get you to click on that chat button in your Zoom toolbar. We're going to be using the chat function for a couple prompts today, so make sure you get familiar with it. Easiest way to do that is type in your name and let us know where you're tuning in from. My name's Troy, and I'm the Director of Operations for Nurses Specialized in Wound, Ostomy, and Continence Canada. I'm tuning in from Ottawa here, and it's nice and sunny. It's 29 degrees outside today, so I'm very happy to see everybody online, but hopefully the weather's good for you there too, so you can go for a walk or hang out a little bit after this webinar today. We're going to be recording today's session, so if you need to head out early or if your colleague needs to come and watch it, we will be making it available on our site after the fact as well. As always, everyone who's online today will be receiving a certificate of attendance. We'll get that to you within a day or two after the webinar. So thanks for your patience there. We are also going to be doing a Q&A portion at the end. So if you have a question for Dr. Evans, click on the Q&A button in your Zoom toolbar. So not the chat, but the Zoom Q&A button, and that'll make it easy for us to organize them and get to as many as we can at the end. So without further ado, I'm happy to introduce Dr. Evans, who's currently the medical director of the Wound Healing Clinic at the Women's College Hospital in Toronto, Ontario, where she is involved in research and teaching. She is also a full-time family physician in the community and is part of the faculty of the International Interprofessional Wound Course through the University of Toronto. She is medical lead for Wounds Canada to support the development of interprofessional education programs for clinicians, as well as delivery and evaluation of these programs. So without further ado, I'm happy to pass over the mic and the slides to Dr. Evans. Thanks for being with us today.
Great. Hi, everybody. Thanks for joining tonight. I know everyone's had a long day. I would like to thank ECHO for supporting this educational session and for thinking of these topics. I think the pain one is particularly interesting, not something we do a lot about. And so we'll get started with my conflict of interest. These are the same as last time. I do get an honorarium for this presentation. I do work as a consultant for Health Espresso. I'm on the board of Wounds Canada, director of the Wound Care Champion Program through Wounds Canada, and again, co-chairing the Wounds Care National Conference in October. And trust me, this is the last one I'm doing. So the objectives for today is to review the general concepts of pain, what to consider, and then dissect out these causes of pain and how it impacts your patients. And because most of us are focusing on the lower leg, we're going to review the mechanisms of pain relative to the lower leg and ulcers. And then we want to consider what we can do about this pain, medications, and more novel approaches. So I just want to start with pain is what the patient says it is. Now, unfortunately, I had a skiing accident at the end of February, and I don't recommend fracturing the tibial plateau, but it did need to be repaired. And I was getting 1 milligram of hydromorphone every 4 hours, and of course, is that enough? Well, according to me, no, it wasn't. I think I needed 1 milligram per screw in that diagram there. But lots of things do impact pain. I mean, I did manage to up my game in the pain department, but it certainly made me reflect on pain, what patients go through, some of the issues, and some of the things that do contribute to pain other than just the surgery. I mean, things like fatigue, being in hospital, all of these things, but we're going to talk a little bit about as time goes on. So wound pain. So the definition is been developed from the International Association for the Study of Pain, and this was done in 2020. And this is an unpleasant sensory and emotional experience and associated with or resembling that which is associated with actual or potential tissue damage. So this takes into account many aspects of pain. And, you know, reading through the literature, there's a lot of stuff written on pain, some of it good, bad, some of it a little bit out there, but it is recognized that pain is underassessed and undertreated, unfortunately. But 80% of people with venous leg ulcers describe mild to moderate pain, and patients in hospital, when they looked at acute and chronic pain, would suggest it's mild to severe pain, and about 90% felt they were undertreated. That's really unfortunate as well. The effect on quality of life, when this is looked at alone, it is the most bothersome symptom. And most ulcers will have pain, except if you have some sort of neuropathic issue where you don't really feel. So I just want you to put in the chat here, why is pain poorly managed? I think everyone's got an opinion about this. Certainly I do. There was an article written in the Advances of Skin and Wound in 2020 looking at 500 respondents from nurses, and they came up with some significant gaps. So what do you guys think? Can I see the chat? I guess I'm gonna
Yeah,
let.
we're seeing some mentions here. Bias. Feel free to type in the chat here. Fear of addiction.
Mm-hmm.
Lack of education, perceived lack of time, personal bias based on their own pain, afraid to seem weak, improper assessment, just the stigma around there. Sometimes just a signal and less obvious as a symptom, some embarrassment, fear of addiction, afraid to bother anyone or bother busy nurses, fear of adverse effects like impaction, believe
Right.
that they are, yeah, there's a mental health component that goes with it, simple staffing availability and proper assessment, a lot of lack of knowledge and improper assessment here. So quite a few different comments coming in.
So I think you agree mainly with this study that was done with 500 nurses, and most of them said it was knowledge, gap in knowledge and awareness, and how to conduct a proper assessment. What do you do, and how do you document this? So, I mean, those are all things that I would agree with, and I think the time element is significant, and the gap in knowledge. And for me, I think one of the things I always worry about, and I think it was mentioned, is side effects to the medication that you're delivering. Who's following that? And a lot of our patients are chronically ill, so something that's tough to do. So there's lots of reasons why, but I think gap in knowledge is one of the big ones. So just review the types of pain. I think everyone's heard of these types of pain mentioned. Nociceptive, we all imagine this. You imagine you're hammering your finger with a hammer and you know what that feels like. Um, no one needs to describe that to you. Neuropathic, maybe you haven't felt that, but it's lesions or disease in the neural system or somatosensory system that causes problems. Nociceptive is a little bit more difficult to understand because there's really no tissue damage. It's not fully described by either neuropathic or nociceptive, but it's an altered perception with no clear evidence of actual or threatened tissue damage. So I think the thing that most people sort of liken this to is the pain that occurs with fibromyalgia. Neuropathic pain is more if anyone's had shingles or carpal tunnel syndrome, this is the kind of pain that's felt with that. And I don't need to describe nociceptive because we've all done that. So we need to go back a little bit just to remind you of the pain pathway and that we know that pain arises in the periphery. And you can see that at the bottom of the slide where the red lines start to come across into the spinal column. They cross the dorsal root ganglion, go to the other side and up into the brain to the somatosensory system, and also effects in the brain stem and the limbic system. And the important part of that is we know it goes up and we know signals come down, but you can modulate these signals through neurotransmitters. And this is how pain medication works. And we're going to come back to this diagram. Interestingly enough, anticipation is a big factor for pain. They put people in an MRI machine, did a study, and told them when the red lights turned on, they'll receive a small shock. And what's interesting was they did turn on the red light and they had them in the MRI so you could see the brain. The brain lit up as if it was pain before a shock even was observed. So there is a lot of anticipatory pain, which is, I think, what happens sometimes at the bedside when we're managing patients. So it's important if we're going to understand pain, we need to know what we're dealing with here. And it's hard sometimes to discern, but the history as always is the most important part in all of this. Neuropathic pain is a sensory system pain, and it causes this numbness, tingling, pins and needles, burning, shooting, and shock-like sensation. Whereas nociceptive pain or hammering your hand is sharp, stabbing, aching, and throbbing. And when you get this kind of pain with nociceptive pain, one of the first things people do is they grab their hand and they hold on to it and apply pressure. And the reason that works is because The pain fibers are small fibers, whereas large fibers are pressure fibers, and they go to the brain much quicker. So you try to almost block that pain response so that you're actually filling your brain with the other system of pressure rather than the symptom of pain. So it's important to evaluate pain at every single visit. So there is background pain, and that's the pain related to underlying wound pathology, which could be ischemic, inflammatory, infectious. I was going to sort of highlight the slide before I turn it in case anyone was eating dinner, but I think you NSWOCs are all pretty used to this. Can it be incident pain? Various activities can cause pain. Things like if you have back pain, if anyone's had back pain, they know there's certain activities that make it better and worse. Or procedural pain. And this is treatment with cleansing agents, dressings, debridement. And so this needs to be done at each and every visit if you really want to understand how your patient's perceiving pain. Okay. So, but unfortunately, pain is modulated by a lot of other stuff, and certainly, as I alluded to at the beginning, when I was in the hospital, I felt pain was really bad, and it was, and I got better medication. But when I got home, I felt so much better. I had my own bed, I was sleeping, I had my own food. Things got much better, and it does modulate the pain effect. So there's a lot of personal factors, some of them genetic, past experiences, stress and fatigue. There's a lot of emotional factors as well. Anxiety is a big indicator, and I already talked about anticipation of pain. Then there's social, cultural. Some certain groups are way more stoic than others. There may be age, male, female differences, and it's really no two individuals will have the same pain with the same whacking of your hand. Pain is what the patient says it is. A couple of days ago, I guess more than a couple, maybe about a month ago, this gentleman on the right came into the clinic and he, I mean, I know now how stoic he is, but this doesn't look good to anybody on this call, I would say. Um, but this is a red hot foot, extensive deep ulcerations. And he walked in, he was in bed, and he wasn't really complaining. I mean, I did ask him about pain, but probably I wasn't as complete with the pain history because I was pretty worried about this infection, and I was sort of trying to get him set to go to emerge into the emerge and get admitted. But when I saw him walk out, I was just floored at how much pain this guy was having. Never mentioned a thing. In fact, when he came in, he wasn't even thinking his leg was a big deal. He was stoic as could be. And when he came in yesterday, I sort of challenged him on this. He says, "Well, what am I going to do?" And I thought, well, this obviously is something I need to take seriously whenever I see this gentleman because he doesn't complain of anything. So watch your patients. You need to ask about it. And I think somebody brought that up in the last chat that people are embarrassed to bring up pain or they don't want to bother us. So putting this all together, I've created this diagram to sort of help you remember all the concepts that need to be looked at with this chronic pain. So there's background, incident, or procedural pain. And this is probably stuff you're more used to managing, focusing in on whether it's neuropathic, nociceptic, or nociplastic, and then knowing what the environmental, personal factors, cultural, and emotional issues are. And it sometimes takes a long time to work out all these factors, gain the trust of the patient to understand all the aspects of pain that this patient is facing. Now, consequences of wound pain. So these are the big ones. I mean, if we don't manage pain, there's always a consequence. And I think the most important of these is the impact on the ability to adhere to the treatment plan that we're suggesting for our patients. Depression can be a cause of chronic pain, can cause as a result of chronic pain. And then quality of life issues, how it is affecting the sleep, appetite, work, social, and mobility, which of course feeds into mood disorders. So they're pretty connected. We know anxiety is a big cause of stress hormones. You can activate the corticotropin releasing hormone in the pituitary. That causes the release of these catecholamines like epinephrine, norepinephrine, and impact wound healing. And there are studies to support this. These higher levels of stress will lead to lower levels of wound healing. So again, I think the therapeutic relationship is really important for your patients. These items you have to sort of take into account. if you want realistic expectations for how you think your wound care plan will be implemented. So wound evaluation. So we always go back to the history. You need to know the cause of the wound. The pain in terms of timing, frequency, intensity, and change are important, and these must both be looked at both background, incident, and procedural. So it is a bit of a time-consuming process to actually get a very good history of pain. The simpler thing that I think a lot of people use are these numeric rating scales that tend to rely heavily on pain intensity. VAS, or visual analog scale, is probably one of the most common ones used. But your facilities probably has one that they prefer. Most of the literature that evaluates pain is related to intensity mostly. There's other aspects, not really too much, but the McGill pain questionnaire is much more in-depth and considers more social and psychological impact on quality of life, and a more complete questionnaire. And it is much more possible to differentiate between both the nociceptic and neuropathic pain. So I think this is one of the limiting factors for why we don't do this, is because it takes time. Obviously, if you're just doing a visual analog scale, it's a quick questionnaire or a quick put your dot on the line. But if you really want to understand pain, you need to go further. So we need to know the cause in our chronic leg wounds, and this is just the shopping list that everyone is probably familiar with to understand what the etiology is. And we know that arterial or ischemic ulcers are pretty common. Neuropathic, we discussed, metabolic, diabetes related, and other metabolic diseases. Unusual or sinister infections like TB or blastomycosis, in the right history. Malignant is not that uncommon on the lower leg. And then we have inflammatory diseases like vasculitis and pyoderma gangrenosum that may complicate the lower leg. But again, most of us are dealing with venous leg ulcers that represent 70% of what we're seeing. Okay, so to hone in on the lower leg, just to remind you of the causes of venous hypertension. Valvular incompetence we know as being important, obstruction, which is really related to blood clots, and failure of the calf muscle pump. So all three of these feed into and ultimately result in venous hypertension. It's this venous hypertension that causes a dilatation of the capillaries, accumulation of blood in the microcirculation. It's not moving out. It involves the skin and the dermis. And with this leaking of the fluid into the interstitium, you have stuff that shouldn't be there. So the white cells, iron, cytokines, and growth factors all accumulate there, sort of promoting this inflammatory response. This inflammation causes further release of proteolytic enzymes, further damage to the capillaries, then that increased permeability with more cells leaking out. So it's a runaway machine here. You get damage to the capillaries. Now, what we really talk about with all of this is the accumulation of deoxygenated blood. So you're not moving the blood out of here. It's all just stagnant now. The oxygen has been diffused already, and we're looking at stagnant blood and edema. And this is what we call areas of venous ischemia. So you might well have good blood flow to the leg if you looked at the arteries, but when you have some venous congestion, you have local areas of venous ischemia. So that's a source of pain on its own, that edema. But the dermatitis as a result of the skin changes and inflammation can be uncomfortable. Lipodermatosclerosis, which is that woody fibrosis that you feel in the lower leg that eventually goes on to look like that champagne bottle deformity. If you put pressure on that, it's painful. And that's why I think a lot of people have trouble with compression. Ulceration is the final product at the end result of a venous hypertension, and that is, of course, where skin breakdown and tissue damage and that nociceptor starts the whole process of pain. Edema on its own is uncomfortable. Just to go back to, as I sat in bed thinking, my biggest concern when I had my leg issue was I had all this swelling in my ankle. And the biggest thing I thought, when my heel is so sore, that edema in the heel can easily see how you quickly get a pressure injury, but the edema on its own is extremely uncomfortable. So after I drew that diagram, I guess it took me an hour some Saturday morning. My husband comes down and says, "What are you doing?" And I show him that diagram, and he says, "Well, let me talk to ChatGPT and put all this stuff into it." And lo and behold, I get this diagram, which I think is pretty good. I still think mine is better. I take a poll, but I'm just thinking mine's a little bit more complete. But it is kind of neat looking, and maybe for PowerPoints, it is, interesting to have a more interesting slide when you're on the Zoom calls. But venous hypertension, again, you got capillary adhesion, you get all those inflammatory cytokines. You see them more drawn out here. Capillary distension, release of protease, again, this hypoxia or ischemia, edema. And then ultimate product is the pain, which can be neuropathic and nociceptive. Pretty good diagram, though. So we know that venous leg ulcers hurt because of these chemical irritants that the nociceptors are activating. We've all heard of substance P, but bradykinins and prostaglandins as well. And then we have the mechanical stress of edema and tissue breakdown. You can even get a peripheral or central sensitization or heightened pain response. Once pain's been there for a long period of time, you can get this heightened pain response, similar almost to the nociplastic kind of pain. And then you get all these issues of pain worsened by some of the things that we're doing at the bedside that we need to think about. Often venous leg ulcers start simply with the nociceptive pain and evolve into both nociceptic and neuropathic. So we know that they hurt. Well, so I just want you to put in the chat here. I hope everyone's still awake. While at the bedside, what do you consider in terms of pain when providing care? What do you do? What do you think about? If you, Troy, can just help us out with this, and we can get an idea just to keep everybody awake and see what we're thinking of.
Absolutely. Definitely type in the chat here. I see some people raising hands, but if you can just put in the chat, we can read those out for you. I know it's a longer question, so give a little bit of time here. Pre-Medicaid, elevation, frequent checking in with the patient, grimacing if they're nonverbal, warm blankets, giving meds early, assessment, history, repositioning. Pain is a vital. Always check for pain. Distractions, assess. Pain is what the patient says it is. Someone's paying attention here. Giving meds early, providing comfortable position. Try to use different terminology when assessing. Dressing removal and paying close attention to selection of dressings to reduce pain. Indirect assessment, relationship with the patient first on first visit. Give meds at appropriate times before pain gets out of hand. Providing meds early. Taking breaks.
Oh, that's a good one. Yeah.
Yeah. Soak the wound dressing. Have a conversation throughout with the patient. And if they need a break, I'll stop sometimes, looking at cleaning. Pain is what's described in listening to the client. Advise the patient to take medication before wound care. We're getting lots of great comments here. Plan
Yeah, you know
ahead.
what? If we all
Yeah.
worked together, these patients would never have pain. I think we got a lot of stuff there. I like the warming blanket, changing position,
Yeah.
timeouts. Distraction techniques are reported to be pretty
Oh,
good.
another one here, understanding their spirituality. So the cultural sensitivity side as well here too. Yep.
Great. Amazing. Well, as a group, we got everything. Problem is, what do we do at the bedside when we're by ourselves? It's a little harder. So many things to think about when you're at the bedside. You have, I know you have time commitments. I mean, you're all great NSWOC nurses, I know, but there's a lot to think about. And the patients are also asking you lots of questions and distracting you. So good for you to think of all of those. I think you got 100%. So we do need to manage pain at debridement. We know we need to reduce bioburden to accelerate wound healing. So there are topical agents you can use prior to debridement. Oral analgesics were already mentioned. There are topical agents like the eutectic mixture of local anesthetic, EMLA. You have to apply a thick later under occlusion, and this takes a lot of time, so you have to plan. Injecting 1% lidocaine into the peri wound, if you really had to, if there was something you needed to do, would be an option. But of course, this can sting. You have to use a very thin needle, and there's certain better ways of injecting the lidocaine. At our clinic, we tend to just put 4% lidocaine on gauze and put it on the ulcer. Leave it there. I go see a couple more patients come back, and patients tell me it really does help. They ask for it, so it is an option. And you need to consider your debridement method. You may not be able to do everything at first visit. You might use another method in between. And as maybe the pain gets better, you can do more. But the nice thing and the bad thing about chronic wounds, I mean, obviously they're chronic and that's not ideal, but you do get to see your patients more often. And what you don't do this time, you can do next time. You can plan better once you know the pain is going to be an issue. All right, the cleansing agents. So avoiding excessive irrigation, use adequate volumes, and that was mentioned in the chat. Warm the cleansing agent as possible if it's a big concern. Avoid cytotoxic agents. And what we might think is cytotoxic or not, it is to the patient. So even 1 in 9 acetic acid in water, as you're probably all aware, great to remove Pseudomonas, but it can be very difficult for some patients to tolerate. There's new products on the market that are meant to debride wounds more mechanically. You have to consider whether these would be appropriate for your patients. Avoiding abrasive woven gauzes may be also important. Dressings, how you put it on, take it off. Pulling dressings away from fragile skin, particularly the elderly, is an issue. Slow removal, providing counter traction. Consider the type of dressing and the frequency. Numbers of studies have been done with silicone, and they looked at actually the amount of cells on the stratum corneum of dressings when they removed them. And silicone certainly wins all around on that one. So silicone might be an option if pain is really bad. But assessing your moisture. This is a big deal. The enzyme-rich exudate damages the peri-wound, causes more background pain. And so the dressing choice, the frequency of the dressing, and skin barriers would be a consideration. And then we have this product called ibuprofen foam dressing. In the right patient, it does have evidence to work. Of course, you have to have enough fluid from the wound to activate this. It is a foam dressing, so if it's super, super wet, it may not be appropriate. But you do need to think of many aspects of cleansing and dressing. Certainly, looking at the literature on pain, the dressing is the most important consideration for the patient with pain. And I think this is someplace that we can easily do better by pre-treating and being cautious with our dressings, how we remove them. And sometimes getting the patient to remove their own dressing is the key. Compression, okay, this is a big one. Pain can limit the use of compression, and sometimes that can be up to 50%. And I sort of alluded to that, with the lipodermatosclerosis can be uncomfortable. So you have to consider the type, the strength, the material, and of course, devices to help with application. The pictures on the left are not what we really want to see, but these are some of the things that have come into my clinic. And obviously, it's unclear to me how the top picture could go on happening, but the bottom picture I get, maybe the compression wasn't put on to the top and you got this tourniquet effect. But not only, I mean, compression has to be adequately put on by somebody who's properly trained to put on compression. And we know from previous talks that there's alternatives to treating this with pentoxyviolin, which, as you may recall, is a xanthine derivative, sort of like caffeine, that is used, and it increases the deformability of red cells. And if you do that, you might increase perfusion to tissues that are not getting well perfused. And then using a device like Gecko, which we know helps with edema and reducing it that way if compression is not a problem. And of course, combination therapy, you might be able to use light compression with maybe pentoxyviolin and Gecko and really get an effect of reducing your edema and helping with pain. Now, a sudden increase in pain. Everyone should sit up and take notice and rule out a blood clot. So that's the DVT at the bottom. That's the first thing on your list. But also think of bioburden. Pain is a validated indicator of infection. Biofilms release toxins and more proteases. And again, we know what proteases do. Proteases are going to cause more inflammation, break down tissue. So a big problem. Biofilms, big problem. 90% of chronic wounds have these biofilms. And when your wound isn't getting better, and it looks like if there's exudate, inflamed granulation tissue, odor, and pain, you think of infection. But when the antibiotics are not working, pushing this wound forward, biofilms is often the problem, and you have to use your biofilm management strategies to help. Dressings are a big issue with pain, with infection. So the big five anti-infective agents, which are the polyhexamethylene biguanate, gentian violet, methylene blue, and cadexamer iodine, honey, and silver. These are all options, plus or minus contraindications and patient factors, but useful to decrease pain when there's local infection. Obviously, if there's spreading infection, oral antibiotics would be indicated, and those of you in the audience that can prescribe would be certainly doing that. Those of you who can't, obviously, would be referring. So pharmacology is a big ticket item, and it was mentioned in the initial chat, side effects. So it's important to consider the type of pain, the timing, the intensity. We talked about this, but also the patient factors, the allergies, drug interactions, side effects, and the ever so present comorbidities. And remember that pharmacological agents, it's a win if you get 30% effective. For chronic pain, non-opioids first. We all love acetaminophen for its low potential for side effects. We want to stay below 3 grams per day, so important to educate your patients. Non-steroidal anti-inflammatory drugs like NSAIDs, great for pain. Unfortunately, the side effect profile for most of our patients is not ideal if they're on antiplatelet agents already, or they're at risk for kidney disease, GI bleeds. Big issue. You have to be very brave to be writing prescriptions for NSAIDs to these patients. Selected antidepressants is more where we go, and anticonvulsants. The opioids are not first line, and there's good reason for this. I think the pendulum has obviously gone far too far away from the use of opioids. Obviously, we need to be cognizant of the concern for overdose, misuse, diversion, or morbidity, but in some cases, they absolutely are necessary, and it's very important to start slow and monitor side effects. And I think if you are seeing your patients regularly, this is something that you can do, but you have to watch out for the constipation, dizziness, and risk for falls. So back to this. We know that different pain medications work differently. So if you're looking at the ascending pathway, and more this is nociceptive pain, acetaminophen, NSAIDs, menthol, cannabinoids are mentioned. There's some evidence, ketamine, which may eventually be more commonly used, are drugs that would affect this ascending pathway. And then modulating how the pain is felt is the descending pathway. And we have anti-epileptics, gabapentinoids, sodium channel agents, antidepressants, and these are the TCAs, tricyclic antidepressants, serotonin, norepinephrine, cannabinoids, and ketamines can modulate how this pain is affected. But again, sometimes you have to use combination therapy for this. Okay, so neuropathic pain, if we look at that specifically, these are the treatment options that have been developed that are considered effective for neuropathic pain. The tricyclic antidepressants, amitriptyline is probably most commonly used, dosing starting very low at 10 milligrams. You may decide to use its cousin nortriptyline, again starting at 10 milligrams and watching for effect and side effect. The serotonin and norepinephrine reuptake inhibitors, duloxetine is the one used most commonly and certainly being used more often, 30 milligrams once a day, and you can increase the dose as time goes on, again, watching for side effects. Phenylvaccine is also used for the same reasons, and again, it can be started at 25 milligrams, but it's a slow progression upwards. So you really do need to follow the patients. Anticonvulsions are used a lot, pregabalin and gabapentin. Their dosage range is wide, and again, starting slow and going up. There was a study done in 2021 in France looking at a lot of pain medication, and there was a bit more negativity in the use of pregabalin in terms of effect and tolerability, more in favor of the gabapentin. That was news to me. It was a learning moment. Also, that these gabapentinoids do have to be watched in terms of respiratory depression when used with opioids. And again, opioids are moderately effective. They're part of the scenario that you might have to use, but again, start with something else and add if you need to. But the real thing is we need to use combination techniques, and this was as laid out in the European Wounds Management Position Statement, that more than one method is necessary. Now, just to, I want to keep everybody awake, and I'm always interested in hearing what everybody else has to say. What pearls do you have regarding any pain or evaluation that we already haven't talked about in terms of pain? May it be pharmacological, things you've noticed, anything you want to share with your colleagues? Because I think there's a fair number of people here on the line. And I'll get
We've got
Troy.
some good points here about, oops, getting a call at the same time here. Uh, Waiting for a couple more comments to come in, but I know from before people were talking about looking at the drainage type, color, odor, keeping that in mind as we go, and welcoming any other comments here if anyone wants to put in things they've been using in their own practice to keep this in mind here. Feel free to
Yeah,
type in the chat.
inflammatory oxidate for sure is a big concern. I mean, that's toxic to the skin and increases tissue breakdown and is a big source of pain. Around dressings, this is where we all shine in the NSWOCs and everybody else at the bedside is a lot of the pain is stuff you actually do at the bedside. I mean, you can go into background pain, but the local stuff is a big ticket item.
Yeah, I'm looking for signs of infection, keeping in mind the wound location, nausea, whether nausea has been an
Yeah,
issue, letting the client remove and help with wound cleaning, so
right,
bringing them into their care as well. Again, another comment about assessing odor, assess after cleansing as well, and noting before, this is the change in odor. Refrigeration of appropriate creams, using non-adhesive dressings sometimes, reassessing whether current meds are working or whether they need to change. Again, letting the patient remove their own dressing to see how they're doing it.
right.
Yeah, so some great comments coming in here. We can leave it open for a little bit if you want there, but
Sure.
it looks like
Yeah, we
we've
can go back to
there we
that.
go.
Sure.
Yeah.
Yeah, the reassessment part is key. I mean, you're not going to know if something works and let and you guys see your patients probably weekly or every 2 weeks, a lot of you. And so it's the perfect time to figure out what's actually working and making
Mhm.
changes.
This is a good comment here too about rephrasing the assessment rather than using negative words to describe the pain, but responding or changing the wording, I guess, from a positive, I guess, using positive language or different types of language to describe the types of pain.
Right. It's really about engaging your patients and making them partners in the care and really understanding and getting, I mean, they have to trust you. And so I think, just engaging in the pain conversation is already gaining that trust and recognizing as soon as we often walk into a room, the first thing we want to do is rip off the dressing and look at the wound. We want to see if it's better or worse. Can't wait. It's like opening a Christmas present. But you really got to take it back a step and let the patient sort of lead in some ways and assume, don't pick up the scalpel right away. Um, I certainly have learned that over the years. Okay, so we need to think of other options. And if we look at gecko, that's going to be one of the options to look at a study. We already looked at this before, and we got to remember there's other things that are going on in the background for pain. And cognitive behavioral therapy has evidence. Hyperbaric oxygen, probably mostly for ischemic pain, but it has been used significantly. Mindfulness, stress reduction management. Nitroglycerin ointments, very effective. I've seen it really effective in scleroderma patients and more scleroderma, I would say, than ischemic. There's topical patches that can be used, and there's so many more. I mean, there's distraction techniques, getting the patients to sleep properly. All of these lifestyle, quality of life issues help with the pain that we need to really think about. So looking at the gecko, if we go back and look at the impact of the new intervention for venous leg ulcers that I talked about with edema last time with Dr. Harding's paper, I kind of like this paper because it was a run-in phase, so it sort of it eliminates heterogeneity. It sort of self controls. So you do a 4 week or 28-day workup just with standard of care and then intervention and go forward. So what they used and published was the primary endpoint of rate of advance of the wound edge. But they did look at other stuff that is interesting. And I think the one I'm going to show today is the visual analog scale, looking at the pain that's achieved with the gecko instead of just the primary endpoint of advancing wound edge. So here's the diagram. Now, this is undergoing peer review at the moment, but shows good results in managing pain. So again, if you look on the x-axis, you have days, and on the y-axis, you have this visual analog scale showing pain. And graphing there is the first 28 days, which is standard of care, run-in phase, and then the big arrow in the middle is the onset of the gecko and then monitoring the visual analog scale after application of the gecko, which was used 12 hours per day. So as you can see, the big ticket item here is the intervention at day 28, and you see that the slope of that line is dramatically come down, and you can see that there's a quick effect, which then levels off. So if you look at the two studies today together, I mean, the one on the right is just standard of care at 28 days. There's just continued standard of care. You can't actually compare these two cohorts as it wasn't powered for this comparison. So don't compare one to the other. I think the point is that there's an immediate faster rate with the gecko when it's applied, and at 42 days, it kind of settles out, which is probably as the wound heals and the edema responds, the wound pain gets better, but this amount of pain that the person experiences is significantly reduced. I think this is a good starting point for where we need to go with this, looking at different modalities, because we know pharmacologically you can only go so far, maybe 30%, and maybe not even that if you can't find the pharmacological agent that is safe enough for your patients to use. So looking at why does something like the muscle pump activator work? Why is that? Well, one of the reasons we talked about this local venous ischemia, and we do know from previously published studies just on the circulation, that gecko itself improves the circulation, microcirculation around the areas of the lower leg. And we know from the study that it accelerated healing, advancing wound edge. So all of these taken together can reduce pain. But if you think of that pain diagram, how it goes up into the brain and comes back down, the thought is that the gecko is modulating that sensory input, sort of similar to what a TENS might do. Mechanical receptors are able to modulate the pain and actually cause reduction in how pain is felt. So it's clear that we need to look more studies at pain and quality of life issues as the main endpoint rather than just advancing wound edge. And I think obviously this paper will be published soon, and I guess everybody on this call will probably be aware of it when that happens. So what we need to look for in the future is improved wound care, faster healing of the wounds so we have less pain. We need advancement in basic science. As we all said in the chat, that infection is an important indicator of inflammation, infection, and bioburden. What's happening at the wound bed? How do we see biofilm? How can we deal with it much quicker? And then the evolution of smart dressings, monitoring pH, temperature, oxygen, infection, everything that can go wrong in a wound, but know when it happens quicker. And then use options that increase local blood flow and edema, which accelerate healing. And by definition, accelerated healing will be improved pain. And I always tell the residents that blood flow is a currency of healing. And that's why I've been so interested in using this device to try to improve these hard to heal wounds. And knowing that pain can be improved too would be a big advantage without having the side effects that I worry about with pharmacological. So combination therapy is key. So the take home, remember this diagram on the right, which probably took me too long to draw, and I probably could have got someone smarter than me to do this quicker, but background incident procedural pain and the types of pain. Certain medications are going to affect neuropathic pain different than nociceptive. Nociceptive pain is more Advil or NSAIDs and Tylenol, whereas neuropathic pain is more your gabapentinoids and your duloxetine. Take into consideration the environmental, personal factors, cultural, and emotional issues for your patients to fully understand pain. You need to ask about it, know the cause, listen to your patients to gain trust, to reduce anxiety, and keep revising your treatment plans based on your pain response. And remember that more than one modality is likely necessary for pain because side effects are a big issue pharmacologically. So, I mean, there's different options and there are so many. I want to leave you with these references if anybody wants some extra reading on pain. And thank you very much for your attention. And hopefully the questions I can answer. If not, maybe somebody smarter than me in the audience can do that. Thanks again for your attention. I appreciate you joining the webinar tonight.
Well, thank you so much, Dr. Evans. This has been a fantastic presentation, a really important topic, and I think it is one of the first times where we've maybe been discussing this. It's definitely in our webinar series. So really, really great topic, and thank you again for the presentation. We do have some questions
Oh, good
here,
stuff.
so
Thanks for
maybe
all the
we'll,
stuff flying through the air here.
yeah, lots of emojis,
That's
lots of
kind of
clapping
cool.
hands,
I've never
lots of
seen that
thank yous in the
before.
chat too.
That is
Yeah,
really
keep them
cool.
coming.
That is.
Our one question here, and this is sort of leaping off at the end, we were talking about, again, making sure we're talking with our patient and everything, including them as a part of their treatment and pain management here. One person is asking a question a little bit specific to their client here. They've just started with a client with pyoderma gangrenosum. Her pain has been so unmanaged for so long, 7 years, she says, that she's lost hope. She doesn't
Yeah.
trust going to a pain management clinic and says that they can't and or have not been able to help her. How do you approach managing such pain in a case like this and some of that distrust potentially that a patient's been experiencing
Yeah, I
or a
think
client?
the gaining the trust is most important. I mean, I think there are ways of, I mean, obviously her PG has to be managed in terms of the proper medication to handle her PG, and I don't know if that's been done. Obviously, treat the cause, number one. Number two is I think you need to look at various methods to understand her quality of life, what you can do to help with her quality of life, because it's impacting to many different things. She's probably got he or she has got themselves on a treadmill of it's just, it's not going anywhere. So you have to pick a point and try and start from somewhere. See where the patient wants to make the biggest change, to help with the pain. Again, pharmacologically, you can get 30%. You need to try other stuff. I don't know what's been tried so far, but PG can be horrifically painful, as can vasculitis for these patients. And pain clinics, I mean, certainly an option, but I'm wondering if more specialized PG clinic might be a better idea for your patients. I mean, we do have one at Women's College. I'm not trying to promote business, but there is a specialty dermatologist at our clinic, Dr. Cortoro, who does deals with, if that's any help to you.
Thank you for touching on that here. And we had a question coming in just through the chat. Someone was mentioning that they have questions about irritation on the peri-wound area, specifically for venous leg ulcers.
Yeah.
How can we avoid this kind of irritation? What steps can be taken after irritation occurs? I know we've talked about venous leg ulcers quite a few times in this webinar series as well. Is that something you would be able to comment on?
Yeah, I think that's a very good question. I think it's a big contributor to pain. So you have to figure out why you have an exudate. It's not enough just to pile a bunch of dressings on something and hope that you're cleaning it up. First of all, understand what's causing the exudate. Is it inflammation or infection? Or is it a lot of edema in the leg? So you have to make the diagnosis of infection or not. If you deal with that, then you pick the dressing to be an anti-infective if that's the case, and choose a superabsorbent and the right frequency to get control of the exudate until the infection is under control. Also, as soon as you put compression or you do anything to reduce edema, you get a lot of fluid coming out of this wound. So be prepared that you have to up your game on how you manage the exudate. I hope that answers your question.
Yeah, well, thank you for touching on that. And again, for any of these questions about venous leg ulcers specifically too, I also encourage everybody to take a look at some of our past webinars as a part of this same webinar series too. Some great questions and answers that came up specifically related to that. Another question, this is going back earlier on in your presentation here. You're talking about different pain management here and everything. One of the questions was, is a dosage of 400 milligrams of pentoxifylline, you're gonna have to excuse my pronunciation, 3 times a day considered appropriate as an adjunct therapy, an
Yes, it
adjunct
is.
therapy?
400 TID is a recognized dose. Some people do push it to 800. There are GI side effects with pentoxifylline, and sometimes people don't have the coverage for it. So it can be an expense, but it is an option, and I would start with the 400 TID.
Well, thank you for touching on that. We don't have any questions open in the Q&A box right now, but I'll remind everybody that we can still take some here. So if you've got a burning question that you want to get off your chest now, feel free to put it in. Even if you want to put it in the chat, feel free. And we'll see if we'll get one or two more here. But either way, there's been so many great takeaways from today, and it's been really exciting to go over this topic with you. And I know you've been chatting lots, I think, about this topic. I know you said you've been working a little bit on some of the program stuff at Wounds Canada. You've been talking about the upcoming conference for Wounds Canada. Is this something that you'll be talking about, or
You
that
know
will be
what?
brought up at the conference then? Yeah.
I've been really pushing to get a talk on pain, so there should be one. I'm hoping. The agenda's not out, and I hope people will attend. But yes, I even before this topic came up, I think it's something we all struggle with. And I know I struggle with it as well. Being consistent and being quick at managing and taking the pain history and knowing what to do. I think once you look at the structure of this talk tonight, maybe a bit more structure in the clinic, it might help you organize your thoughts a little bit quicker to manage the pain. But again, I think one of the biggest advantages we have is we see our patients more than once usually. We have a period of time to develop a rapport, understand where they're coming from, and manage the pain and start low so they don't get side effects. One of the worst things you can do with patients is give them too much. They get a side effect, the drug is lost. So it's worth the effort of slow titration of medication.
Absolutely. Well, on that note, we've got a question here on potentially a bit more coming into those sort of stigmas, the fear of addiction kind of comments we are talking about at the very beginning. One person's asking, what is your thought on topical morphine uses, maybe specifically for pain management, but also from on the patient or client side, their thoughts on it too.
Yeah, there is some literature on topical morphine it has been mentioned as some of the topical treatments. There's a whole paper just on, the a systematic review on topical agents, and morphine is listed as one as a modulator of pain and does have some evidence. Yes, I think, if you want to use specific types of dressings such as that, I mean, you just have to probably look at the literature, see what the pluses and minuses are, but that is one of them that is mentioned, as well as cannabinoids. I mean, it's plus minus with that, but it still keeps coming up.
Perfect. Well, while we're waiting for a couple other questions here, I just want to remind everyone, especially for those in the chat here, we will be sending out the certificate of attendance to everybody. It'll take usually maximum 2 days, no more than 2 days to get into your email inbox. We'll also send a link to the recording of today's presentation. So it'll be in the next day or two, and it will be posted on our website there. Kim was just asking in the message here, just based on what you were recommending there about the literature on topical morphine. Do you happen to know maybe where that was, or any other information
There
they
was
can use
a
to
there
search it
was
up?
you know what there was a paper on topical. I can send that. I don't know if I listed it in my
Well,
uh,
tell you what we can even do too
yeah,
is
I
maybe
did.
in the
I did
post,
on the
it
the
is in the
last.
references there.
It's in
Okay.
references number 2 on systematic review of topical interventions for the management of pain and chronic wounds, 2023. So that
Perfect. And
is really good, and it goes through the details of topical agents.
that's perfect. And maybe we can, I'll take that out maybe and put it into the email that comes out after, just in case people want to get the link. That's no problem at all. Now, I guess the question here, I know we've got both Kathy Bros and Jeff Fernie from Perfuse MedTech behind the scenes with us. One person was just asking about whether Gecko is available in Canada. Did you want to maybe, Jeff or Kathy, was there anything you wanted to maybe talk about with respect to Gecko?
Yeah. So I'm just having trouble. Yeah, the question was, is it widely available in Canada? And the answer is yes. We do have some challenges in some areas, such as Ontario, where we're working on the formulary because it was on the formulary for home care and then was taken off. But that's being worked on. There was also NIHB questions. The answer is yes, we're very much working on that. The main areas used in Canada right now is long-term care, but certainly it's absolutely available. And so there's another question, Troy, that
Yeah, go for it.
So what was the second question? Or did I miss
No,
that?
that was it. Just making sure where it was available, and thank you for touching
Yeah.
on the NIHB comment. I know that came up a little bit earlier in
Yeah.
the presentation. Yeah.
Yeah, the only other thing I'd like to add, and I realize Robyn can't really speculate on the future with this, but one of the things we find is that there's an impact in biochemistry, and we've seen impact on a fibrolytic effect, D-dimer, and endothelial function. So there's likely something in blood flow that is impacting pain management, and I think that's something that we need to look at in the future. But right now it's that's a hypothesis, but we certainly can't make that as a claim.
Yeah, well, thank you for touching on that. And I just wanted to say thank you again, Perfuse MedTech, for making this education possible, not just today, but a part of this multi-part series. We're going to be having another presentation coming up in just a couple weeks here. It's going to be on not even less than that now. It'll be just under 2 weeks away on June 17th. We're going to be talking about treatment strategies for diabetic foot ulcers as well. And I'll be with Dr. Gary Sibbald. For those who are looking for the link in the to watch all the past webinars, including the past ones from this series on wound care strategies for keeping the patient at home and in the community, you can click on the link I put in the chat there. We'll also include it when we send you that certificate as well.
Sorry, Troy, before we
Yeah,
go,
go for it.
I think Wendy Whalen posted the most important message of all. Go Oilers, go.
Absolutely.
Go Oilers, go.
There you go. Start of the Stanley Cup Finals today. Okay,
Game's
well,
on
we'll
in an
echo
hour,
that
so,
for
yeah.
all of our Canadian colleagues across Canada here today. We're all with the
Well,
Oilers,
you're
unless
off
you're.
on you're off on time to watch the game.
We're all
Yeah.
Oilers fans tonight.
There
Yeah.
we go. Awesome.
This
Well,
is
thank
your
you so
pregame
much,
warm-up.
Doc. That's it. Well, thank you so much, Dr. Evans, for your great presentation today. Again, there's been so many thank yous and great comments in the chat, so we really appreciate you taking the time. And again, do go check out our website there to get registered for our next upcoming webinar. We've got quite a few coming up for next week as well, but also the final component of the webinar series that we were mentioning on June 17th. Thanks again to you, Jeff, to Kathy behind the scenes, and to Perfuse MedTech, and we look forward to seeing everybody soon.
Thanks,
Thanks so
everyone.
much.
Cheers.
Good night.